Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. New onset geriatric syndromes and 1-year outcomes following elective gastrointestinal cancer surgery. Objective: to assess whether older adults who develop geriatric syndromes following elective gastrointestinal surgery have poorer 1-year outcomes. Background: within 10 years, 70% of all cancers will occur in older adults greater than or equal to 65 years old. The rise in older adults requiring major surgery has brought attention to age-related complications termed geriatric syndromes. However, whether postoperative geriatric syndromes are associated with long-term outcomes is unclear. Methods: a population-based retrospective cohort study using the New York State Cancer Registry and the statewide planning and research cooperative system was performed, including patients greater than 55 years with pathologic stage I3 esophageal, gastric, pancreatic, colon, or rectal cancer who underwent elective resection between 2004 and 2018. Those aged 55 to 64 served as the reference group. The exposure of interest was a geriatric syndrome, fracture, fall, delirium, pressure ulcer, depression, malnutrition, failure to thrive, dehydration or incontinence, urinary/fecal, during the surgical admission. Patients with any geriatric syndrome within 1 year of surgery were excluded. Outcomes included incident geriatric syndrome, 1-year days alive and out of the hospital, and 1-year all-cause mortality. Results: in this study, 37,998 patients with a median age of 71 years without a prior geriatric syndrome were included. Of those 65 years or more, 6.4% developed a geriatric syndrome. Factors associated with an incident geriatric syndrome were age, alcohol/tobacco use, comorbidities, neoadjuvant therapy, ostomies, open surgery, and upper gastrointestinal cancers. An incident geriatric syndrome was associated with a 43% higher risk of 1-year mortality, hazard ratio, 1.43, 95% confidence interval, 1.27 to 1.60. For those aged 65 plus discharged alive and not to hospice, a geriatric syndrome was associated with significantly fewer days alive and out of hospital, 322 versus 346 days, p less than 0.0001. There was an indirect relationship between the number of geriatric syndromes and 1-year mortality and days alive and out of the hospital after adjusting for surgical complications. Conclusions: given the increase in older adults requiring major surgical intervention, and the establishment of geriatric surgery accreditation programs, these data suggest that morbidity and mortality metrics should be adjusted to accommodate the independent relationship between geriatric syndromes and long-term outcomes. Quality of life and real-time patient experience during neoadjuvant therapy, a prospective cohort study. Objective: to use a customized smartphone application to prospectively measure call and the real-time patient experience during neoadjuvant therapy, NT. Background: NT is increasingly used for patients with localized gastrointestinal (GI) cancers. There is little data assessing patient experience and quality of life (QOL) during NT for GI cancers. Methods: patients with GI cancers receiving NT were instructed on using a customized smartphone application through which the Functional Assessment of Cancer Therapy General (FACT-G) questionnaire, a validated measure of health-related call, was administered at baseline, every 30 days, and at the completion of NT. Participants also tracked their moods and symptoms and used free text journaling functionalities in the application. Mean overall and subsection health-related call scores were calculated during NT. Results: among 104 enrolled patients, the mean age was 60.5 plus or minus 11.5 years, and 55% were males. Common cancer diagnoses were colorectal, 40%, pancreatic, 37%, and esophageal, 15%. Mean overall FACT-G scores did not change during NT, p equals 0.987. While functional well-being scores were consistently the lowest and social well-being scores the highest, FACT subscores similarly did not change during NT, all p greater than 0.01. The most common symptoms reported during NT were fatigue, insomnia, and anxiety, 39.3%, 34.5%, and 28.3% of patient entries, respectively. Qualitative analysis of free text journaling entries identified anxiety, fear, and frustration as the most common themes, but also the importance of social support systems and confidence in healthcare providers. Conclusions. While patient symptom burden remains high, results of this prospective cohort study suggest call is maintained during NT for localized GI cancer. New Sarculator prognostic nomograms for patients with primary retroperitoneal sarcoma. Case volume does matter. Objective: to update the current Sarculator retroperitoneal sarcoma (RPS) prognostic nomograms considering the improvement in patient prognosis and the case volume effect. Background: survival of patients with primary RPS has been increasing over time, and the volume-outcome relationship has been well recognized. Nevertheless, the specific impact on prognostic nomograms is unknown. Methods: all consecutive adult patients with primary localized RPS treated at 8 European and North American sarcoma reference centers between 2010 and 2017 were included. Patients were divided into two groups: high-volume centers, HVC, greater than or equal to 13 cases/year, and low-volume centers, LVC, less than 13 cases/year. Primary endpoints were overall survival, OS, and disease-free survival, DFS. Multivariable analyses for OS and DFS were performed. The nomograms were updated by recalibration. Nomograms performance was assessed in terms of discrimination, Harrell C index, and calibration plot. Results: the HVC and LVC groups comprised 857 and 244 patients, respectively. The median annual primary RPS case volume, interquartile range, was 24.0 in HVC, 15.0 to 41.3, and 9.0 in LVC, 1.8 to 10.3. 5-year OS was 71.4%, 95% C, 68.3% to 74.7% in the HVC cohort and 63.3%, 56.8% to 70.5% in the LVC cohort, p equals 0.012. Case volume was associated with both OS, LVC versus HVC hazard ratio 1.40, 95% C, 1.08 to 1.82, p equals 0.011, and DFS, hazard ratio 1.93, 95% C, 1.57 to 2.37, p less than 0.001, at multivariable analyses. When applied to the study cohorts, the Sarculator nomograms showed good discrimination, Harrell C index between 0.68 and 0.73. The recalibrated nomograms showed good calibration in the HVC group, whereas the original nomograms showed good calibration in the LVC group. Conclusions: new nomograms for patients with primary RPS treated with surgery at high volume versus low volume sarcoma reference centers are available in the Sarculator. Genetic ancestry-specific molecular and survival differences in admixed patients with breast cancer. Objective: we aim to determine whether incremental changes in genetic ancestry percentages influence molecular and clinical outcome characteristics of breast cancer in an admixed population. Background: patients with breast cancer are predominantly characterized as Black or white based on self-identified race/ethnicity or arbitrary genetic ancestry cutoffs. This limits scientific discovery in populations that are admixed or of mixed race/ethnicity, as they cannot be classified based on historical race/ethnicity boxes or genetic ancestry cutoffs. Methods: We used the Cancer Genome Atlas cohort and focused on genetically admixed patients that had less than 90% European, African, Asian, or Native American ancestry. Results: genetically admixed patients with breast cancer exhibited improved 10-year overall survival relative to those with greater than 90% European ancestry. Within the luminal A subtype, patients with lower African ancestry had longer 10-year overall survival compared to those with higher African ancestry. The correlation of genetic ancestry with gene expression and DNA methylation in the Admixed cohort revealed novel ancestry-specific intrinsic PAM50 subtype patterns. In luminal A tumors, genetic ancestry was correlated with both the expression and methylation of signaling genes, while in basal-like tumors, genetic ancestry was correlated with stemness genes. In addition, we took a machine learning approach to estimate genetic ancestry from gene expression or DNA methylation, and were able to accurately calculate ancestry values from a reduced set of 10 genes or 50 methylation sites that were specific for each molecular subtype. Conclusions: our results suggest that incremental changes in genetic ancestry percentages result in ancestry-specific molecular differences even between well-established PAM50 subtypes, which may influence disparities in breast cancer survival outcomes. Accounting for incremental changes in ancestry will be important in future research, prognostication, and risk stratification, particularly in ancestrally diverse populations. Association between whole blood transfusion and mortality among injured pediatric patients. Objective: the aim of this study was to assess the association between whole blood, WB, and mortality among injured children who received immediate blood transfusion. Background: the use of WB for transfusion therapy in trauma has been revisited, and recent studies have reported an association between WB and improved survival among adults. However, evidence of a similar association lacks in children. Methods: we performed a retrospective cohort study from the American College of Surgeons Trauma Quality Improvement Program, ACS-TQIP, between 2020 and 2021. Patients were aged less than or equal to 16 years and had immediate blood transfusion within 4 hours of hospital arrival. Survival at 24 hours and 30 days were compared after creating 1-to-1 propensity score matched cohorts, matching for demographics, injury type, vital signs on admission, trauma severity scores, hemorrhage control procedures, hospital characteristics, and the need for massive transfusion. Results: a total of 2,729 patients were eligible for analysis. The median age was 14 years, interquartile range, 8 to 16 years, 1862, 68.2%, patients were male, and 1,207, 44.2%, patients were white. A total of 319, 11.7%, patients received WB. After a 1-to-1 ratio propensity score matching, 318 matched pairs were compared. WB transfusion was associated with improved survival at 24 hours, demonstrating a 42% lower risk of mortality, hazard ratio 0.58, 95% C, 0.34 to 0.98, p equals 0.042. Similarly, the survival benefit associated with WB transfusion remained consistent at 30 days, hazard ratio 0.65, 95% C, 0.46 to 0.90, p equals 0.011. Conclusion: the use of WB was associated with improved survival among injured pediatric patients requiring immediate transfusion. Next article is from Journal of American Medical Association Surgery. 3-year outcomes of oral antibiotics versus intravenous and oral antibiotics for uncomplicated acute appendicitis, a secondary analysis of the APPAC-2 randomized clinical trial. Importance: current short-term evidence has shown that uncomplicated acute appendicitis can be treated successfully with oral antibiotics alone, but longer-term results are lacking. Objective: to assess the treatment effectiveness of oral antibiotic monotherapy compared with combined intravenous, and oral antibiotics in computed tomography confirmed uncomplicated acute appendicitis at a longer-term follow-up. Interventions: antibiotics monotherapy consisted of oral moxifloxacin, 400 mg/d for 7 days. Combined 4 and oral antibiotics consisted of 4 ertapenem sodium, 1 gram/d, for 2 days plus oral levofloxacin, 500 mg/d, and metronidazole, 500 mg 3 times/d, for 5 days. Main outcomes and measures. The primary endpoint was treatment success, defined as the resolution of acute appendicitis and discharge from hospital without the need for surgical intervention and no appendicitis recurrence at the year 3 follow-up, evaluated using a non-inferiority design. The secondary endpoints included late, after 1 year, appendicitis recurrence as well as treatment-related adverse events, quality of life, length of hospital stay, and length of sick leave, which were evaluated using a superiority design. Results after exclusions: 599 patients, mean SD, age, 36, 12 years, 336 males, 56.1%, were randomized. After withdrawal and loss to follow-up, 582 patients, 99.8%, were available for the year 3 follow-up. The treatment success at year 3 was 63.4%, one-sided 95% C, 58.8% 2, in the oral antibiotic monotherapy group, and 65.2%, one-sided 95% C, 60.5% 2, in the combined 4 and oral antibiotics group. The difference in treatment success rate between the groups at year 3 was minus 1.8 percentage points, one-sided 95% C, minus 8.3 percentage points 2, p equals 0.14 for non-inferiority, with the C limit exceeding the non-inferiority margin. There were no significant differences between groups in treatment-related adverse events, quality of life, length of hospital stay, or length of sick leave. Conclusions and relevance: this secondary analysis of the APPAC-2 trial found a slightly higher appendectomy rate in patients who received oral antibiotic monotherapy. However, non-inferiority of oral antibiotic monotherapy compared with combined 4 and oral antibiotics could not be demonstrated. The results encourage future studies to assess oral antibiotic monotherapy as a viable treatment alternative for uncomplicated acute. Next, we will be discussing articles from British Journal of Surgery. Autofluorescence-guided hemithyroidectomy in a low-volume thyroid institution with no experience in parathyroid surgery, randomized clinical trial. Background: recent studies suggest that low-volume surgeons with no experience in parathyroid surgery are at increased risk of causing parathyroid gland damage during thyroid surgery. The aim of this RCT was to evaluate the impact of using autofluorescence in hemithyroidectomy on parathyroid gland identification and preservation in a low-volume institution with no experience in parathyroid surgery. Methods: patients referred for hemithyroidectomy were randomized 1 to either autofluorescence-guided hemithyroidectomy, the near-infrared autofluorescence group, or conventional hemithyroidectomy, the control group. The primary outcome was parathyroid gland identification rate. Secondary outcomes were the rate of parathyroid gland autotransplantation and the rate of inadvertent parathyroid gland excision. Results: a total of 170 patients were randomized to either autofluorescence-guided hemithyroidectomy, 84 patients, or conventional hemithyroidectomy, 86 patients. In the near-infrared autofluorescence group, 81.0% of parathyroid glands were identified, compared with 57.0% in the control group, p less than 0.001. Autofluorescence enabled parathyroid gland visualization before the naked eye in 46.3% of cases. Surgeons had lower confidence in the parathyroid gland identification process in the control group than in the near-infrared autofluorescence group, 59.1% versus 87.5% respectively, p less than 0.001. In the near-infrared autofluorescence group, the parathyroid gland autotransplantation rate was initially high, but declined over time. There was no difference in the rate of inadvertent parathyroid gland excision. Conclusion: autofluorescence guidance significantly improved the parathyroid gland identification rate in hemithyroidectomy, a low-volume institution with no experience in parathyroid surgery, and provided an increase in surgical confidence. The pattern of parathyroid gland autotransplantation in autofluorescence-guided surgery indicates the presence of a learning curve. Next we will be discussing articles from Journal of Vascular Surgery. The Natural History and Long-Term Follow-up of Splenic Artery Aneurysms. Objective. Although splenic artery aneurysms, SAS, are the most common visceral aneurysm, there is a paucity of literature on the behavior of these entities. The objective of this study was to review the natural history of patients with SA. Methods. This single institution, retrospective analysis studied patients with SA diagnosed by computed tomography imaging between 2015 and 2019, identified by our institutional radiology database. Imaging, demographic, and clinical data were obtained via the electronic medical record. The growth rate was calculated for patients with radiologic follow-up. Results. The cohort consisted of 853 patients with 890 SAS, of whom 692 were female, 81.2%. There were 37 women, 5.3%, of childbearing age, 15 to 50 years. The mean age at diagnosis was 70.9 years, range, 28 to 100 years. Frequently observed medical comorbidities included hypertension, 70.2%, hypercholesterolemia, 54.7%, and prior smoking, 32.2%. Imaging indications included abdominal pain, 37.3%, unrelated follow-up, 28.0%, and follow-up of a previously noted visceral artery aneurysm, 8.6%. The mean diameter at diagnosis was 13.3 plus or minus 6.3 millimeters. Anatomic locations included the splenic hilum, 36.0%, distal splenic artery, 30.3%, mid-splenic artery, 23.9%, and proximal splenic artery, 9.7%. Radiographically, the majority were saccular aneurysms, 72.4%, with calcifications, 88.5%. One patient, 38-year-old woman, was initially diagnosed at the time of rupture of a 25 mm aneurysm. This patient underwent immediate endovascular intervention with no complications. The mean clinical follow-up among 812 patients was 4.1 plus or minus 4.0 years, and the mean radiological follow-up among 514 patients was 3.8 plus or minus 6.8 years. Of the latter, 122 patients, 23.7%, experience growth. Aneurysm growth rates for initial sizes less than 10 mm, n equals 123, 10 to 19 mm, n equals 353, 20 to 29 mm, n equals 34, and greater than 30 mm, n equals 4, were 0.166 mm/y, 0.172 mm/y, 0.383 mm/y, and 0.246 mm/y, respectively. Of the entire cohort, 27 patients, 3.2%, eventually underwent intervention, 81.5% endovascular, with the most common indications including size/growth criteria, 70.4%, and symptom development, 18.5%. On multivariate analysis, only prior tobacco use was significantly associated with aneurysm growth, p equals 0.028. Conclusions. The majority of SAS in this cohort remains stable in size, with few patients requiring intervention over a mean follow-up of 4 years. Current guidelines recommending treatment of asymptomatic aneurysms greater than 30 mm appear appropriate given their slow progression. Despite societal recommendations for intervention for all SAS among women of childbearing age, only a minority underwent vascular surgical consultation and intervention in this series, indicating that these recommendations are likely not well known in the general medical community. Long-term outcomes of carotid endarterectomy versus transfemoral carotid stenting in a Medicare Match database. Background. Carotid endarterectomy, CEA, is associated with lower risk of perioperative stroke compared with transfemoral carotid artery stenting, TCAS, in the treatment of carotid artery stenosis. However, there is discrepancy in data regarding long-term outcomes. We aim to compare long-term outcomes of CEA versus TCAS using the Medicare Matched Vascular Quality Initiative Vascular Implant Surveillance and Interventional Outcomes Network database. Methods. We assessed patients undergoing first-time CEA or TFCAS in Vascular Quality Initiative Vascular Implant Surveillance, and Interventional Outcomes Network from January 2003 to December 2018. Patients with prior history of carotid revascularization, non-transfemoral stenting, stenting performed without distal embolic protection, multiple or non-atherosclerotic lesions, or concomitant procedures were excluded. The primary outcome of interest was all-cause mortality, any stroke, and a combined endpoint of death or stroke. We additionally performed propensity score matching and stratification based on symptomatic status. Results: a total of 80,146 carotid revascularizations were performed, of which 72,615 were CEA and 7,531 were TFCAS. CEA was associated with significantly lower risk of death, 57.8% versus 70.4%, adjusted hazard ratio R 0.46, 95% confidence interval C 0.41 to 0.52, P less than 0.001, stroke 21.3% versus 26.6%, R 0.63, 95% C 0.57 to 0.69, P less than 0.001, and combined endpoint of death and stroke 65.3% versus 76.5%, HR 0.49, 95% C 0.44 to 0.55, P less than 0.001 at 10 years. These findings were reflected in the propensity matched cohort, combined endpoint 34.6% versus 46.8%, HR 0.53, 95% C 0.46 to 0.62, at 4 years, as well as stratified analyses of combined endpoint by symptomatic status, asymptomatic, 63.2% versus 74.9%, HR 0.49, 95% C 0.43 to 0.58, P less than 0.001, symptomatic, 69.9% versus 78.3%, HR 0.51, 95% C 0.45 to 0.59, P less than 0.001 at 10 years. Conclusions: in this analysis of North American real-world data, CEA was associated with greater long-term survival and fewer strokes compared with TFCAS. These findings support the continued use of CEA as the first-line revascularization procedure. Aortic endarterectomy in patients with severe multivessel paravisceral and aortoiliac occlusive disease. Objective: aortic endarterectomy, once a treatment of choice for aortoiliac occlusive disease, is now rarely performed in favor of endovascular procedures or open aorta bifemoral bypass. However, in select patients with paravisceral or aortoiliac occlusive disease, A remains a viable alternative for revascularization, either as a primary procedure or after prior interventions have failed. Results: 5 patients, 25%, underwent paravisceral endarterectomy and 15, 75%, underwent aortoiliac endarterectomy. There were no perioperative mortalities. 1 paravisceral patient died 3 months postoperatively from complications of pneumonia. 3 patients in the paravisceral group required reinterventions, 1 acutely due to thrombosis of the superior mesenteric artery, SMA, requiring extension of the endarterectomy and patch angioplasty on postoperative day 0, 1 due to stenosis at the distal edge of the endarterectomy 1 month postoperatively, successfully treated with SMA stenting, and 1 at 10-month follow-up due to SMA stenosis at the distal aspect of the endarterectomy, also successfully treated with SMA stenting. With these reinterventions, the 1-year primary patency in the paravisceral group was 40%, primary assisted patency was 80%, and secondary patency was 100%. In the aortoiliac group, 1-year primary, primary assisted, and secondary patency were 91%, 91%, and 100%, respectively. 1 patient developed iliac thrombosis 10 days postoperatively owing to an intimal flap distal to the endarterectomy site. She and 1 other patient, a young man with an undefined hypercoagulable disorder, ultimately required neoadjuvant reconstructions at 18 and 32 months postoperatively, respectively, the latter in the setting of stopping anticoagulation. The remaining 13 patients experienced no complications. All patients had rapid resolution of clinical symptoms, and median postoperative ankle brachial indexes of 1.06 on the right and 1.00 on the left, representing a median improvement from preoperative ankle brachial indexes of plus 0.59 on the right and plus 0.56 on the left, p less than 0.01 and p less than 0.01. Conclusions. In this series of 20 patients undergoing paravisceral and infrarenal aortoiliac endarterectomy, A was associated with no perioperative mortality, relatively low and manageable morbidity, and excellent clinical outcomes in patients with both paravisceral and aortoiliac occlusive disease. SMA-related early reintervention was not uncommon in the paravisceral group, and attention should be given particularly to the distal endarterectomy site. A remains a viable treatment for severe multivessel paravisceral or aortoiliac occlusive disease isolated to the aorta and common iliac arteries in select patients. Improved long-term functional outcomes and mortality of patients with vascular-related amputations utilizing the lower extremity amputation pathway. Background. Enhanced recovery after surgery pathways lead to improved perioperative outcomes for patients with vascular-related amputations. However, long-term data and functional outcomes are lacking. This study evaluated patients treated by the lower extremity amputation pathway, LEAP, and identified predictors of ambulation. Methods. A retrospective review of LEAP patients who underwent major amputation from 2016 to 2022 for wound, ischemia, and foot infection stage V disease was performed. LEAP patients were matched 1-to-1 with retrospective controls, no LEAP, by hospital, need for guillotine amputation, and final amputation type, above knee versus below knee. The primary endpoint was the Medicare Functional Classification Level, K level, functional classification of patients with amputations, at the last follow-up. Results. We included 126 patients with vascular-related amputations, 63 LEAP and 63 no LEAP. 71% of the patients were male and 49% were Hispanic with a mean state area deprivation index of 9/10. There were no differences in baseline demographics or comorbidities. All patients had a K level of greater than 0, ambulatory, before amputation and an average modified frailty index of 4. The median follow-up was 270 days, interquartile range, 84 to 1,234 days, in the no-LEAP group and 369 days, interquartile range, 145 to 481 days, in the LEAP group. Compared with no-LEAP patients, LEAP patients were more likely to receive a prosthesis, 86% versus 44% p greater than 0.001. LEAP patients were more likely to have a K level of greater than 0, 60% versus 25%, p equals 0.003. On multivariable logistic regression, participation in LEAP increased the odds of a K level of greater than 0 at follow-up by 5.8-fold, odds ratio, 5.8, 95% confidence interval, 2.5 to 13.6. Patients with a K level of greater than 0 had significantly higher survival at 4 years, 93% versus 59%, p equals 0.001. In a Cox proportional hazards model, adjusted for demographics, comorbidities and amputation level, a K level of greater than 0 at follow-up was associated with an 88% decrease in the risk of mortality compared with a K level of 0. Conclusions. LEAP leads to improved ambulation with a prosthesis in a socioeconomically disadvantaged and frail patient population. Patients with a K level of greater than 0, ambulatory, have significantly improved mortality. Discordance of patient-reported outcome measures with objectively assessed walking decline in peripheral artery disease. Objective. Among people with peripheral artery disease, PAD, perceived change in walking difficulty over time, compared with people without PAD, is unclear. Among people reporting no change in walking difficulty over time, differences in objectively measured change in walking performance between people with and without PAD are unknown. Methods. A total of 1,289 participants were included. 874 participants with PAD, age 71.1 plus or minus 9.1 years, were identified from non-invasive vascular laboratories, and 415 without PAD, age 69.9 plus or minus 7.6 years, were identified from people with normal vascular laboratory testing or general medical practices in Chicago. The Walking Impairment Questionnaire and 6-minute walk were completed at baseline and 1-year follow-up. The Walking Impairment Questionnaire assessed perceived difficulty walking due to symptoms in the calves or buttocks on a Likert scale, range 0 to 4. Symptom change was determined by comparing difficulty reported at 1-year follow-up to difficulty reported at baseline. Results: at 1-year follow-up, 31.9% of participants with and 20.6% of participants without PAD reported walking difficulty that was improved, p less than 0.01, whereas 41.2% versus 55%, respectively, reported walking difficulty that was unchanged, p less than 0.01. Among all reporting no change in walking difficulty, participants with PAD declined in 6-minute walk, whereas participants without PAD improved, minus 10 versus plus 15 meters, mean difference, minus 25, 95% confidence interval, minus 38 to minus 13, p less than 0.01. Conclusions: most people with PAD reported improvement or no change in walking difficulty from calf or buttock symptoms at 1-year follow-up. Among all participants who perceived stable walking ability, those with PAD had significant greater declines in objectively measured walking performance, compared with people without PAD. Next article is from Surgical Endoscopy. Evaluation of a novel home-based laparoscopic and core surgical skills program, Monash Online Surgical Training Introduction. Limitations to surgical education access were exacerbated during the COVID-19 pandemic. In response, we created a national home-based comprehensive surgical skills course, Monash Online Surgical Training, MOST. Our aim was to evaluate the educational impact of this approach. Methods: a remote, 6-week course was designed with learning objectives aligned to the national surgical training. Participants received a personal laparoscopic bench trainer, instrument tracking software, live webinars, access to an online theoretical learning platform, and individualized feedback by system-generated or expert surgeons' assessments. Mixed method analysis of instrument tracking metrics, pre- and post-course questionnaires, 11 core surgical domains, and participant comments was utilized. Data were analyzed using the Mann-Whitney U test, and a p-value of less than 0.05 was considered statistically significant. Results: a total of 54 participants with varied levels of experience, 1 to greater than 6 years postgraduate level, completed most. All 11 learning outcome domains demonstrated statistically significant improvement, including core laparoscopic skills, 1. 4/5 versus 2. 8/5, p less than 0.0001, and handling laparoscopic instruments, 1. 5/5 versus 2. 8/5, p less than 0.0001. A total of 3,460 tasks were completed, reflecting 158.2 hours, 9,492 minutes, of practice. 394 were submitted for formal feedback. Participants rated the course, mean 8. 5/10, SD 1.6, live webinars, mean 8. 9/10, SD 1.6, and instrument tracking software, mean 8.6, SD 1.7, highly. Qualitative analysis revealed a paradigm shift, including the benefits of a safe learning environment and self-paced, self-directed learning. Conclusion: the MOST course demonstrates the successful implementation of a fully remote laparoscopic simulation course, which participants found to be an effective tool to acquire core surgical skills. The effect of internal orifice narrowing in laparoscopic inguinoscrotal hernia repair to prevent seroma formation, a prospective double-blind randomized controlled trial. Objectives: seroma represents the most prevalent postoperative complication following laparoscopic inguinal hernia repair, particularly in the case of large inguinoscrotal hernias. This randomized controlled trial was undertaken with the objective of assessing the effects of internal orifice narrowing achieved by suturing the divided distal hernia sac in laparoscopic repair of indirect inguinoscrotal hernias. Methods: A total of 58 patients aged 18 years or older were randomized into two groups, Group I, which underwent internal orifice narrowing, and Group II, which served as the control without narrowing. The study's primary endpoint was the incidence and volume of seroma in the inguinal region on postoperative days 1 and 7, as well as at 1, 3, and 6 months following the procedure. Secondary outcomes encompassed metrics like total operative time, acute and chronic pain levels, duration of hospital stay, recurrence rates, and the occurrence of any additional complications. Results. In comparison to the control group, the experimental group exhibited a significantly lower incidence of seroma formation at 7 days, p equals 0.001. Furthermore, the ultrasonic assessment indicated a reduced seroma volume in the operative group on postoperative day 7, 8.84 plus or minus 17.71 versus 52.39 plus or minus 70.78 milliliters, p less than 0.001. Acute pain levels and hospital stay were similar between the two groups, 1.22 plus or minus 0.76 versus 1.04 plus or minus 0.53, p equals 0.073, 1.22 plus or minus 0.07 versus 1.19 plus or minus 0.08, p equals 0.627, respectively. Notably, neither chronic pain nor early recurrence, nor any other postoperative complications were observed in either group throughout the follow-up period, which extended for at least 6 months, range 6 to 18 months. Conclusion. In the context of laparoscopic inguinoscrotal hernia repair, the incidence and volume of seroma can be significantly reduced through the implementation of internal orifice narrowing achieved by suturing the divided distal hernia sac. And this reduction in seroma formation was not associated elevation in postoperative pain levels or recurrence rates. Comparative outcomes and prognostic indicators in adrenalectomy for adrenal metastasis. Purpose. The indications for adrenalectomy and feasibility of laparoscopic adrenalectomy for adrenal metastasis are controversial. This study aimed to compare the surgical outcomes between open adrenalectomy, OA, and laparoscopic adrenalectomy, LA, and to evaluate the prognostic factors for oncological outcomes of adrenal metastasis. Materials and methods. We conducted a retrospective chart review of 141 consecutive patients who underwent adrenalectomy for adrenal metastasis at Seoul National University Hospital from April 2005 to February 2021. Surgical and oncological outcomes were compared between OA and LA. Results. OA was performed in 95, 67.4% patients, and 46, 32.6% patients underwent LA. Among the patients who underwent adrenalectomy without adjacent organ resection for adrenal tumors less than 8 cm, LA was associated with a shorter operation time, 100.1 plus or minus 48.8 versus 158.6 plus or minus 81.2, p equals 0.001, less blood loss, 94.8 plus or minus 93.8 versus 566.8 plus or minus 1156.0, p equals 0.034, and a shorter hospital stay, 3.7 plus or minus 1.3 versus 6.9 plus or minus 5.8, p equals 0.003. For locoregional recurrence-free survival, LRRFS, on multivariate analysis, a positive pathological margin, hazard ratio, HR, 5.777, p equals 0.002, disease activity at the primary site, HR, 6.497, p equals 0.005, other metastases, HR, 4.154, p equals 0.015, and a relatively larger tumor size, HR, 1.198, p equals 0.018, were significantly associated with poor LRRFS. Multivariate analysis indicated that metachronous metastasis, HR, 0.51, p equals 0.032, was associated with a longer overall survival, OS, whereas a positive pathological margin, HR, 2.40, p equals 0.017, metastases to other organs, HR, 2.08, p equals 0.025, and a relatively larger tumor size, HR, 1.11, p equals 0.046, were associated with a shorter OS. Conclusions. LA is a feasible treatment option for adrenal metastasis in selected patients. The pathological margin, metastases to other organs, and tumor size should be considered in adrenalectomy for adrenal metastasis. Next article is from Annals of Surgical Oncology. Prognostic value of myostatosis and creatinine to cystatin C ratio in patients with pancreatic cancer who underwent radical surgery. Background. Myostatosis is correlated with poor prognosis in some malignancies. The creatinine to cystatin ratio, CCR, is revealed to predict gastric cancer prognosis. However, the prognostic abilities of CCR and the combination of CCR and myostatosis in patients with pancreatic cancer, PC, who underwent radical surgery remains unclear. Methods. The retrospective cohort study included 215 patients with PC who underwent radical surgery, January 2016 – October 2021. Clinicopathological and serological data were collected on admission. Myostatosis and other body composition indices were assessed by using computed tomography. The cutoff value of CCR was determined by using the Uden index. Risk factors responsible for poor overall survival, OS, and disease-free survival, DFS, were determined by the Cox proportional hazards model. Results. The myostatosis group included 104 patients, average age, 61.3 plus or minus 9.1 years. The best cutoff value for CCR was 1.09. CCR less than or equal to 1.09 was an independent predictive biomarker inversely correlated with OS, p equals 0.036. Myostatosis was an independent risk factor associated with OS and DFS, p equals 0.032 and p equals 0.004, respectively. Patients with concomitant myostatosis and CCR less than or equal to 1.09 had the worst OS, p equals 0.016. Conclusions. Myostatosis and CCR are prognostic biomarkers for survival in PC patients who underwent radical surgery. Patients with the coexistence of myostatosis and CCR less than or equal to 1.09 deserve more attention. Medicaid expansion increases access for rural and impoverished patients with pancreatic ductal adenocarcinoma in southern states. Introduction. Medicaid expansion, ME, impacted patients when assessed at a national level. However, of the 32 states in which Medicaid expansion occurred, only 3 were southern states. Whether results apply to southern states that share similar geopolitical perspectives remains elusive. We aim to assess the impact of ME on pancreatic ductal adenocarcinoma, PDAC, treatment in 8 southern states in the USA. Patients and methods. We identified uninsured or Medicaid patients, age 40 to 64 years, diagnosed with PAC between 2011 and 2018 in southern states from the North American Association of Central Cancer Registries Cancer in North America, (CNA) research dataset. Medicaid expanded states, MES, Louisiana, Kentucky, and Arkansas, were compared with non-MES, NS, Tennessee, Alabama, Mississippi, Texas, and Oklahoma, using multivariate logistic regression. P less than 0.05 was considered statistically significant. Results. Among 3,036 patients, MES significantly increased odds of Medicaid insurance by 36%, and increased proportions of insured Black patients by 3.7%, rural patients by 3.8%, and impoverished patients by 18.4%. After adjusting for age, race, rural-urban status, poverty status, and summary stage, the odds of receiving radiation therapy decreased by 26% for each year of expansion in expanded states, p equals 0.01. Last main did not result in a significant difference between MES and NS in diagnosing early-stage disease, p equals 0.98, nor in receipt of chemotherapy or surgery, p equals 0.23 and p equals 0.63, respectively. Conclusions. ME in southern states increased insurance access to traditionally underserved groups. Interestingly, Maine decreased the odds of receiving radiation therapy yearly and had no significant impact on receipt of chemotherapy or surgery. Detection and management of perioperative hyperglycemia at a tertiary cancer center. Introduction. To improve the detection and management of perioperative hyperglycemia at our tertiary cancer center, we implemented a glycemic control quality improvement initiative. The primary goal was to decrease the percentage of diabetic patients with median postoperative glucose levels greater than 180 mg/dl during hospitalization by 15% within 2 years. Methods. A multidisciplinary team standardized preoperative screening, preoperative, intraoperative, and postoperative hyperglycemia management. We included all patients undergoing non-emergent inpatient and outpatient operations. We used a t-test, rank sum, chi-square, or Fisher's exact test to assess differences in outcomes between patients at baseline BL 10-2018 to 4-2019 during the first phase, P1 10-2019 to 4-2020, second phase P2 5-2020 to 12-2020, and maintenance phase M 1-2021 to 10-2022. Results. The analysis included 9,891 BL surgical patients, 1,470 with diabetes, 8,815 P1 patients, 1,233 with diabetes, 10,401 P2 patients, 1,531 with diabetes, and 30,410 M patients, 4,265 with diabetes. The percentage of diabetic patients with median glucose levels greater than 180 mg/dl during hospitalization decreased 32% during the initiative, BL 20.1%, P1 16.9%, P2 12.1%, M 13.7%, P less than 0.001. We also saw reductions in the percentages of diabetic patients with median glucose levels greater than 180 mg/dl intraoperatively, BL 34.0%, P1 26.6%, P2 23.9%, M 20.3%, P less than 0.001, and in the post-anesthesia care unit, BL 36.0%, P1 30.4%, P2 28.5%, M 25.8%, P less than 0.001. The percentage of patients screened for diabetes by hemoglobin A1C increased during the initiative, BL 17.5%, P1 52.5%, P2 66.8%, M 74.5%, P less than 0.001. Conclusions. Our successful initiative can be replicated in other hospitals to standardize and improve glycemic control among diabetic surgical patients. Total 3-dimensional guided laparoscopic radical resection for left parahilar cholangiocarcinoma. Background. The application of 3-dimensional, 3D, reconstruction has been extensively adopted in hepatectomy navigation, yet its utilization in laparoscopic radical resection of parahilar cholangiocarcinoma, FCA, remains underexplored. Video. A 54-year-old male patient, classified as child Pu-B, presented a small neoplasm situated at the left hepatic duct proximate to the right hepatic and common hepatic ducts. An enhanced abdominal computed tomographic scan identified a solitary lesion measuring 2.8 times 2.4 centimeters. 3D reconstruction exposed tumor invasion into the left hepatic artery and left portal vein. Given the lesion's unique location, a pure laparoscopic left hepatectomy and caudate lobectomy were executed using a no-touch en-bloc technique post-patient consent. Concurrently, extrahepatic bile duct resection, radical lymphadenectomy with skeletonization, and biliary reconstruction were performed. Results. The 3D reconstruction-guided laparoscopic left hepatectomy and caudate lobectomy were successfully completed in 425 minutes with minimal blood loss, 50 milliliters. The histological grading was T2BN0M0, stage 2. The patient was discharged on the 6th postoperative day without complications, and postoperative treatment included monodrug chemotherapy with capecitabine. No recurrence was observed at the 6-month follow-up. Conclusion. Our experience suggests that 3D reconstruction-guided laparoscopic radical resection may offer increased precision and efficiency in selected for patients. This approach can potentially yield outcomes comparable with or superior to open surgery, given standardized lymph node dissection by skeletonization, use of the node touch end block technique, appropriate digestive tract reconstruction, and reduced bleeding and liver damage. Next article is from Journal of the American College of Surgeons. Using oncolytic virus to retask CD19 chimeric antigen receptor T cells for treatment of pancreatic cancer, toward a universal chimeric antigen receptor T cell strategy for solid tumor. Background. Chimeric antigen receptor, CAR, T cells targeting the B-cell antigen CD19 are standard therapy for relapsed or refractory B-cell lymphoma and leukemia. CAR T-cell therapy in solid tumors is limited due to an immunosuppressive tumor microenvironment and a lack of tumor-restricted antigens. We recently engineered an oncolytic virus, CF33, with high solid tumor affinity and specificity to deliver a non-signaling truncated CD19 antigen, CD19T, allowing targeting by CD19 CAR T cells. Here, we tested this combination against pancreatic cancer. Study design. We engineered CF33 to express a CD19T, CF33 CD19T target. Flow cytometry and ELISA were performed to quantify CD19T expression, immune activation, and killing by virus and CD19 CAR T cells against various pancreatic tumor cells. Subcutaneous pancreatic human xenograft tumor models were treated with virus, CAR T cells, or virus plus CAR T cells. Results. In vitro, CF33 CD19T infection of tumor cells resulted in greater than 90% CD19 T cell surface expression. Co-culturing CD19 CAR T cells with infected cells resulted in interleukin-2 and interferon gamma secretion, upregulation of T cell activation markers, and synergistic cell killing. Combination therapy of virus plus CAR T cells caused significant tumor regression, day 13, control, and equals 16, 485 plus or minus 20 M3, virus alone, n equals 20, 254 plus or minus 23 M3, p equals 0.0001, CAR T cells alone, n equals 18, 466 plus or minus 25 M3, p equals ns, and virus plus CAR T cells, n equals 16, 128 plus or minus 14 M3, p less than 0.0001 versus control. P equals 0.0003 versus virus. Conclusions. Engineered CF33 CD19T effectively infects and expresses CD19T in pancreatic tumors, triggering cell killing and increased immunogenic response by CD19 CAR T cells. Notably, CF33 CD19T can turn cold immunologic tumors hot, enabling solid tumors to be targetable by agents designed against liquid tumor antigens. Postoperative global period cost reduction using 3 successive risk stratified pancreatectomy clinical pathways. Background. We hypothesized that iterative revisions of our original 2016 risk stratified pancreatectomy clinical pathways would be associated with decreased 90-day perioperative costs. Study design. From a single institution retrospective cohort study of consecutive patients with 3 iterations, version 1, B1, October 2016 to January 2019, V2, February 2019 to October 2020, and V3, November 2020 to February 2022. Institutional data were aggregated using revenue codes and adjusted to constant 2022 dollar value. Grand total perioperative costs, primary endpoint, were the sum of pancreatectomy, inpatient care, readmission, and 90-day global outpatient care. Proprietary hospital-based costs were converted to ratios using the mean cost of all hospital operations as the denominator. Results. Of 814 patients, Pathway V1 included 363, V2 229, and V3 222 patients. Accordion grade 3 plus complications decreased with each iteration, V1, 28.4%, V2, 22.7%, and V3, 15.3%. Median length of stay decreased, V1, 6 days in terquartile range, IQR, 5 to 8, V2, 5, IQR 4 to 6, and V3, 5, IQR 4 to 6, without an increase in readmissions. 90-day global perioperative costs decreased by 32%, V1 cost ratio 12.6, V2 10.9, and V3 8.6. Reduction of the index hospitalization cost was associated with the greatest savings, minus 31%, 9.4, 8.3, and 6.5. Outpatient care costs decreased consistently, 1.58, 1.41, and 1.04. When combining readmission and all outpatient costs, total post-discharge costs decreased 3.17, 2.59, and 2.13. Component costs of the index hospitalization that were associated with the greatest savings were room or board costs, minus 55%, 1.74, 1.14, and 0.79, and pharmacy costs, minus 61%, 2.20, 1.61, and 0.87, all p less than 0.001. Conclusions. 3 iterative risk stratified pancreatectomy clinical pathway refinements were associated with a 32% global period cost savings, driven by reduced index hospitalization costs. This successful learning health system model could be externally validated at other institutions performing abdominal cancer surgery. Social determinants of outcomes disparity among pediatric patients with solid tumor. Background. Socioeconomic factors have a significant impact on healthcare outcomes. Metrics such as Area Deprivation Index, ADI, are used to quantify the anticipated influence of these factors. Here, we sought to assess the impact of socioeconomic factors on clinical outcomes among pediatric patients with solid tumor in our region. Study design. We identified 3,863 pediatric patients who were diagnosed with a malignant solid tumor in the Texas Cancer Registry between 1995 and 2019. ADI was used to quantify socioeconomic determinants of health. These outcome variables were determined: stage of disease at diagnosis, time between diagnosis and treatment initiation, and overall mortality. Statistical analysis was performed using logistic regression, linear regression, Cox proportional hazards regression, and Kaplan-Meier survival curves. Results. A total of 53.5% of patients were male and the average age at diagnosis was 4.5 years. 47% of patients were white, 13.3% were black, 36.2% were Hispanic, 1.7% were Asian, and other rare minority groups made up 1.8%. On multivariable analysis, increased risk of death was associated with Black race, rare minority race, residence in a border county, and increasing ADI score, with the risk of death at 5 years rising 4% with each increasing ADI point. Conclusions. Social determinants of health are associated with disparate outcomes among pediatric patients with solid tumor. Our results suggest that patients who are part of racial minority groups and those who reside in socioeconomically disadvantaged neighborhoods or regions near the Texas-Mexico border are at an increased risk of death. This information may be useful in strategizing outreach and expanding resources to improve outcomes in at-risk communities. Exploring the clinical use of molecular profiling of intrahepatic cholangiocarcinoma in a comprehensive multidisciplinary clinic. Background. Molecular profiling of intrahepatic cholangiocarcinoma, ICC, can detect actionable molecular alterations and guide targeted therapies. We explore the clinical use of molecular profiling of ICC in our comprehensive multidisciplinary clinic. Study design. Patients with a tissue diagnosis of ICC seen between 2019 and 2023 were identified. A retrospective review was performed to identify their molecular profiles and targeted therapy. The association between the detection of actionable molecular alterations and overall survival, OS, from the first clinic visit date was studied. Patients with an OS of less than 2 months were excluded. Results. Among 194 patients with ICC, 125 had molecular profiling. Actionable molecular alterations were detected in 56, 45% patients, including microsatellite instability, N equals 3, high tumor mutational burden, greater than 10 mut/MB, N equals 5, isocitrate dehydrogenase 1 and 2 mutations, N equals 22 and 6, respectively, BRAF V600E mutations, N equals 2, phosphatidylanocetal 4,5 bisphosphate 3 kinase, catalytic subunit alpha mutations, N equals 7, breast cancer 1 and breast cancer 2 mutations, N equals 5, mesenchymal epithelial transition amplification, N equals 2, fibroblast growth factor receptor 2 and 3 fusions, N equals 13, ERB2 receptor tyrosine kinase 2 overexpression, N equals 6, and receptor tyrosine kinase 1 fusion, N equals 1. 21 patients received targeted therapies during their treatment course. Survival analysis revealed that for 120 patients with molecular profiling, the detection of an actionable molecular alteration was associated with improved mean OS, 34.1 versus 23.6 months, p equals 0.008. Among 70 patients with non-metastatic ICC, the detection of an actionable molecular alteration was associated with improved mean OS, 32.1 versus 27.5 months, p equals 0.02. Conclusions. Actionable molecular alterations were frequently observed in patients with ICC. Detection of actionable alterations was associated with improved OS. The role of targeted therapy needs further exploration in prospective multi-center studies. Frail patients undergoing optimization before surgery, preliminary results. It is estimated that 10% or more of patients older than 65 years are affected by frailty, a mental and physical state of vulnerability to adverse surgical outcomes. Frailty can be assessed using the Edmonton Frailty Scale, a reliable and convenient multidimensional assessment before surgery. The correlation between frailty score, presurgical optimization, and surgical outcomes was investigated in this preliminary pilot study. Study design. A retrospective study was performed on patients referred to the Surgical Optimization Clinic and assessed for frailty from September 2020 to May 2023. Patients received presurgical optimization for reasons including diabetes, smoking cessation, prehabilitation and nutrition, and/or cardiopulmonary issues. Outcomes were evaluated whether they proceeded to surgery, were referred to the high-risk surgical committee, surgical case canceled, or not scheduled. For those who proceeded to surgery, infection rates, complications, and 30-day emergency department, ED, and readmission rates were evaluated. Results. Of 143 unique patients, 138, men equals 61, women equals 77, were evaluated for this study. The average Edmonton frailty score for patients who proceeded to surgery was 7.013, N equals 78, versus 9.389 with cancellation and 9.600 for not scheduled or not optimized for surgery. Postoperative infection rates were less than 3%. However, 30-day ED and readmission rate was 21%, 16 of 78. Conclusions. Patients with lower average Edmonton frailty scores were more likely to proceed to surgery, whereas those with higher average Edmonton frailty scores were more likely to have surgery cancelled or delayed. Frail patients cleared for surgery were found to have a high 30-day ED and readmission rate. Effect of behavioral health disorders on surgical outcomes in cancer patients. Background. Behavioral health disorders, BHDs, can often be exacerbated in the setting of cancer. We sought to define the prevalence of BHD among cancer patients and characterize the association of BHD with surgical outcomes. Study design. Patients diagnosed with lung, esophageal, gastric, liver, pancreatic, and colorectal cancer between 2018 and 2021 were identified within Medicare Standard Analytic Files. Data on BHD defined as substance abuse, eating disorder, or sleep disorder were obtained. Postoperative textbook outcomes, no complications, prolonged length of stay, 90-day readmission, or 90-day mortality, as well as in-hospital expenditures and overall survival were assessed. Results. Among 694,836 cancer patients, 46,719, 6.7%, patients had at least one Bahraini dinar. Patients with BHD were less likely to undergo resection, no BHD, 23.4% versus BHD, 20.3%, p less than 0.001. Among surgical patients, individuals with BHD had higher odds of a complication, odds ratio, or 1.32, 1.26 to 1.39, prolonged length of stay, or 1.36, 1.29 to 1.43, and 90-day readmission, or 1.57, 1.50 to 1.65, independent of social vulnerability or hospital volume status, resulting in lower odds to achieve A2, or 0.66, 0.63 to 0.69. Surgical patients with BHD also had higher in-hospital expenditures, no BHD, $16,159 versus BHD, $17,432, p less than 0.001. Of note, patients with BHD had worse long-term postoperative survival, median, no BHD, 46.6, 45.9 to 46.7, versus BHD, 37.1, 35.6 to 38.7, months, even after controlling for other clinical factors, hazard ratio 1.26, 1.22 to 1.31, p less than 0.001. Conclusions. BHD was associated with lower likelihood to achieve a postoperative textbook outcome, higher expenditures, as well as worse prognosis. Initiatives to target BHD are needed to improve outcomes of cancer patients undergoing surgery. Defining the problem: 53 years of firearm violence afflicting America's schools. Background: firearm violence and school shootings remain a significant public health problem. This study aimed to examine how publicly available data from all 50 states might improve our understanding of the situation, firearm type, and demographics surrounding school shootings. Study design: school shootings occurring in the U.S. for 53 years ending in May 2022 were analyzed, using primary data files that were obtained from the Center for Homeland Defense and Security. Data analyzed included situation, injury, firearm type, and demographics of victims and shooters. We compared the ratio of fatalities per wounded after stratifying by type of weapon. Rates, among children, of school shooting victims, wounded, and fatalities per 1 million population were stratified by year and compared over time. Results: a total of 2,056 school shooting incidents involving 3,083 victims were analyzed, 2,033 children, 5 to 17 years, and 1,050 adults, 18 to 74 years. Most victims, 77%, and shooters, 96%, were male individuals with a mean age of 18 and 19 years, respectively. Of the weapons identified, handguns, rifles, and shotguns accounted for 84%, 7%, and 4%, respectively. Rifles had a higher fatality to wounded ratio, 0.45, compared with shooters using multiple weapons, 0.41, handguns, 0.35, and shotguns, 0.30. Linear regression analysis identified a significant increase in the rate of school shooting victims, beta equals 0.02, p equals 0.0003, wounded, beta equals 0.01, p equals 0.026, and fatalities, beta equals 0.01, p equals 0.0003, among children over time. Conclusions. Despite heightened public awareness, the incidence of school shooting victims, wounded, and fatalities among children has steadily and significantly increased over the past 53 years. Understanding the epidemic represents the first step in preventing continued firearm violence in our schools. Time kills: impact of socioeconomic deprivation on timely access to guideline concordant treatment in foregut cancer. Background: receipt of guideline concordant treatment, GCT, is associated with improved prognosis in foregut cancers. Studies show that patients living in areas of high neighborhood deprivation have worse healthcare outcomes. However, its effect on GCT in foregut cancers has not been evaluated. We study the impact of the Area Deprivation Index, ADI, as a barrier to GCT. Study design: A single institution retrospective review of 498 foregut cancer patients, gastric, pancreatic, and hepatobiliary adenocarcinoma, from 2018 to 2022 was performed. GCT was defined based on National Comprehensive Cancer Network guidelines. ADI, a validated measure of neighborhood disadvantage, was divided into terciles, low, medium, and high, with high ADI indicating the most disadvantage. Results: of 498 patients, 328, 66%, received GCT, 66%, 72%, and 59% in pancreatic, gastric, and hepatobiliary cancers, respectively. Median interquartile range, time from symptoms to workup was 3 to 13 weeks, from diagnosis to oncology appointment was 1 to 10 weeks, and from oncology appointment to treatment was 2 to 10 weeks. 46% were diagnosed in the emergency department. On multivariable analyses, age 75 years or older, odds ratio, or 0.39, 95% C 0.18 to 0.87, black race, or 0.52, 95% C 0.31 to 0.86, high ADI, or 0.25, 95% C 0.14 to 0.48, 6 weeks or more from symptoms to workup, or 0.44, 95% C 0.27 to 0.73, 4 weeks or more from diagnosis to oncology appointment, or 0.76, 95% C 0.46 to 0.93, and 4 weeks or more from oncology appointment to treatment, or 0.63, 95% C 0.36 to 0.98, were independently associated with non-receipt of GCT. Conclusions: residence in an area of high deprivation predicts non-receipt of GCT. This is due to multiple individual and system-level barriers. Identifying these barriers and developing effective interventions, including community outreach and collaboration, leveraging telehealth, and increasing oncologic expertise in underserved areas, may improve access to GCT. Methylated CNA quantification, non-invasive approach to monitoring hepatocellular carcinoma burden. Background: non-invasive, precision monitoring of hepatocellular carcinoma, HCC, treatment efficacy would greatly facilitate personalized therapy and improve patient outcomes. We hypothesize that quantifying methylated circulating tumor DNA, CNA, can be used to effectively monitor HCC burden without the need for biopsy. Study design: blood samples were collected from 25 patients, 21 with HCC and 4 with benign liver masses, at various time points throughout the course of treatment at a high-volume academic medical center. Quantification of methylated CNA molecules assessed CPG sites on more than 550 pre-selected cancer-specific amplicons. The tumor methylation score, TMS, was calculated by measuring the difference between the amount of methylation in the plasma and buffy coat with a normal cutoff value of 120 or less. Results: among 10 patients with surgical HCC, 5 surgical resections and 5 liver transplants, TMS revealed a statistically significant, rapid postoperative decline in 9. One patient who had a persistently elevated TMS on postoperative day 1 was subsequently found to have had metastatic disease. Patients in the negative control cohort all had normal range pre- and postoperative TMS. Preoperative TMS correlated moderately with tumor burden on pathology, Spearman R equals 0.54, of surgical specimens. From 11 subjects undergoing systemic therapy or Y90 radioembolization, analysis of 16 time periods demonstrated that the change in TMS, delta TMS, was better associated with tumor progression than the change in delta alpha fetoprotein, area under the curves 0.800 and 0.783, respectively. A composite score combining delta TMS and delta alpha fetoprotein further improved performance for detecting tumor progression with an area under the curve of 0.892. Conclusions: these findings indicate that CNA methylation scores can effectively evaluate changes in tumor burden without the need for tumor biopsy. Next article is from Journal of Trauma and Acute Care Surgery. Death by the Minute: Inequities in Trauma Care for Victims of Firearm Violence. Background: Gunshot wounds, GSWs, remain a significant source of mortality in the United States. Timely delivery of trauma care is known to be critical for survival. We sought to understand the relationship of predicted transport time and death after GSW. Given large racial disparities in firearm violence, we also sought to understand disparities in transport times and death by victim race, an unstudied phenomenon. Methods. Firearm mortality data were obtained from the Boston Police Department 2005 to 2023. Firearm incidents were mapped using ARCGIS. Predicted transport times for each incident to the closest trauma center were calculated in ARCGIS. Spatial autoregressive models were used to understand the relationship between victim race, transport time to a trauma center, and mortality associated with the shooting incidents. Results. There were 4,545 shooting victims with 758 deaths. Among those who lived, the median transport time was 9.4 minutes, interquartile range, 5.8 to 13.8, and 10.5 minutes, interquartile range, 6.4 to 14.6, p equals 0.003 for those who died. In the multivariable logistic regression, increased transport time to the nearest trauma center, odds ratio, 1.024, 95% confidence interval, 1.01 to 1.04, and age, odds ratio, 1.016, 95% confidence interval, 1.01 to 1.02, were associated with mortality. There was a modest difference in median transport time to the nearest trauma center by race, with non-Hispanic Black at 10.1 minutes, Black Hispanic 9.2 minutes, White Hispanic 8.5 minutes, and non-Hispanic White 8.3 minutes, p less than 0.001. Conclusion. Our results highlight the relationship of transport time to a trauma center and death after a GSW. Non-white individuals had significantly longer transport times to a trauma center, and predicted mortality would have been lower with white victim transport times. These data underscore the importance of timely trauma care for GSW victims and can be used to direct more equitable trauma systems. An initiative to assess and improve the resources and patient care processes used among Chest Wall Injury Society Collaborative Centers study, CC2 background. Over the last 2 decades, the acute management of rib fractures has changed significantly. In 2021, the Chest Wall Injury Society, CWIS, began recognizing centers that epitomize their mission as CWIS collaborative centers. The primary aim of this study was to determine the resources, surgical expertise, access to care, and institutional support that are present among centers. Methods. A survey was performed including all CWIS collaborative centers, evaluating the resources available at their hospital for the treatment of patients with chest wall injury. Data about each chest wall injury center care process, availability of resources, institutional support, research support, and educational offerings were recorded. Results. Data were collected from 20 trauma centers, resulting in an 80% response rate. These trauma centers were made up of 5 international and 15 US-based trauma centers. 80%, 16 of 20, have dedicated care team members for the evaluation and management of rib fractures. 25%, 5 of 20, have a dedicated rib fracture service with a separate call schedule. Staffing for chest wall injury clinics consists of a multidisciplinary team, with attending surgeons in all clinics, 80%, 8 of 10, with advanced practice providers, and 70%, 7 of 10, with care coordinators. 40%, 8 of 20, of centers have dedicated rib fracture research support, and 35%, 7 of 20, have surgical stabilization of rib fracture, SSRF-related grants. 40%, 8 of 20, of centers have marketing support, and 30%, 8 of 20, have a web page support to bring awareness to their center. At these trauma centers, a median of 4, 1 to 9, surgeons perform SSRFs. In the majority of trauma centers, the trauma surgeons perform SSRF. Conclusion. Considerable similarities and differences exist within these CWIS collaborative centers. These differences in resources are hypothesis generating in determining the optimal chest wall injury center. These findings may generate several patient care and team process questions to optimize patient care, patient experience, provider satisfaction, research productivity, education, and outreach. Mental health symptoms and engagement in a step care mental health service among patients with a violent versus nonviolent injury. Background. Few studies have examined mental health symptom trajectories and engagement in mental health follow-up in relation to mechanism of injury. This study examined differences in engagement between survivors of nonviolent and violent injury in the Trauma Resilience and Recovery Program, TRRP, a step care, technology-enhanced model that provides evidence-based mental health screening and treatment to patients admitted to our Level I trauma service. Methods. This study analyzed data from 2,527 adults enrolled in TRRP at hospital bedside between 2018 and 2022, including 398 patients, 16%, with a violent injury and 2,129 patients, 84%, with a nonviolent injury. Bivariate and hierarchical logistic regression analyses examined relations between injury type, violent versus nonviolent, engagement in TRRP and mental health symptoms at 30-day follow-up. Results. Engagement in services at bedside was similar across survivors of violent and nonviolent traumatic injury. Patients with violent injury had higher levels of post-traumatic stress disorder and depressive symptoms 30 days post-injury but were less likely to engage in mental health screening. Among patients who screened positive for post-traumatic stress disorder and depression, patients with violent injury were more likely to accept treatment referrals. Conclusion. Patients with a violent traumatic injury have higher levels of mental health needs yet face greater barriers to accessing mental health services following their injury relative to those with a nonviolent injury. Effective strategies are needed to ensure continuity of care and access to mental health care to promote resilience and emotional and functional recovery. Next article is from the American Journal of Surgery. Revisiting femoral hernia diagnosis rates by patient sex in inguinal hernia repairs. Introduction. Guidelines recommend MEIS repairs for females with inguinal hernias, despite limited evidence. We investigated rates of femoral hernias intraoperatively noted during MEIS and Liechtenstein repairs in females. Methods. A.I.C. was queried for adult females undergoing inguinal hernia repair between January 2014 and November 2022. Outcomes included identified femoral hernia and size, hernia recurrence, quality of life, and sex-based recurrence. Results. 1,357 and 316 females underwent MEIS and Liechtenstein inguinal repair respectively. Femoral hernias were identified more frequently in MEIS than open repairs, 27% vs 12%, p less than 0.001. Most femoral hernias in MEIS, 61%, and Liechtenstein repairs, 62%, were less than 1.5 cm, p less than 0.001. Identification rates of femoral hernias greater than 3 cm or 1% overall, p equals 0.09. Surgeon and patient reported recurrences were similar between approaches at 1-5 years for females, p greater than 0.05 for all, and similar between sexes, p greater than 0.05. Conclusion. Most incidental femoral hernias are small and both repair approaches demonstrated similar outcomes. The recommendation for MEIS inguinal hernia repairs in females is potentially overstated. Nipple necrosis rate with submuscular versus prepectoral implant-based reconstruction and nipple-sparing mastectomy, does it differ? Background. This study aims to compare the rate of nipple necrosis between the submuscular, SM, versus the prepectoral, PP, implant placement after immediate breast reconstruction, IBR. Methods. An institutional review board-approved database was reviewed of patients who underwent nipple-sparing mastectomy, NSM, with IBR at our institution between 2016 and 2019. Patients who had SM versus PP IBR were compared. Incidence of nipple necrosis was evaluated between the two groups. Results. A total of 525 NSM with IBR were performed in 320 patients with SM reconstruction in 61%, N equals 322, and PP in 39%, N equals 203, of the mastectomies. Overall, 43 nipples experienced some form of necrosis with 1% of mastectomies experiencing nipple loss. There was no difference between SM group and PP group at the rate of nipple necrosis, 9% versus 7%, p equals 0.71. Conclusion. In patients undergoing NSM with IBR, the rate of nipple necrosis, nipple loss or complications did not differ between groups whether the implant was placed SM or PP, supporting the safety of this newer procedure. Does Commission on Cancer (COC) accreditation mitigate the effect of care fragmentation on clinical outcome in localized rectal cancer? Background. Studies of fragmented care (FC) in rectal cancer have not adjusted for indicators of hospital quality and may misrepresent the effects of FC. Methods. We queried the National Cancer Database to identify patients undergoing care for clinical stage 2 and 3 rectal adenocarcinoma between 2006 and 2019. Those undergoing FC were subcategorized based on whether FC COC or not, FC non-COC, they received systemic therapy at COC-accredited facilities. Results. 44,339 patients met inclusion criteria, 23,921, 54%, underwent FC, 16,929, 71%, FC non-COC. Differences in utilization of neoadjuvant therapy, 92.3% versus 89.7% versus 89.5%, p less than 0.01, and 5-year overall survival, 76.1 versus 75.5 versus 74.1%, p less than 0.01, between treatment cohorts were marginal. Conclusion. In patients undergoing multimodality therapy for rectal cancer, care fragmentation is not associated with long-term clinical outcome. Decisions regarding where these patients go for systemic therapy may be safely made on the basis of ease of access. Optimizing throughput of babies with infantile hypertrophic pyloric stenosis. Background. Definitive surgical care is often delayed in hypertrophic pyloric stenosis, HPS. Our aim is to evaluate the effect modifiable factors in preoperative HPS management have on efficiency of care. Methods. A retrospective review of all patients undergoing pyloromyotomy for HPS at 2 U.S. children's hospitals between 2008 and 2018 was performed. Results. 406 patients were included in the study. The majority, 310, 76%, were adequately resuscitated and ready for surgery upon diagnosis in the ER. However, only 133 patients, 43%, had surgery on the day of admission. Patients diagnosed between 12 p.m. and 6 p.m. were more likely to have surgery the next day than those diagnosed before noon, 67% versus 33%, p less than .001, which correlated with a longer length of stay, 32 versus 47h, p less than .001. Conclusion. The majority of patients presenting with HPS can safely undergo same-day surgery. Delaying surgery due to an afternoon diagnosis is common, and leads to a modifiable increased total length of stay. Next article is from World Journal of Surgery. The unexpected social cost of inguinal herniaplasty procedures derived from the COVID-19 pandemic, surgical trend analysis based on an Italian hospital series. Background. The majority of inguinal hernias are usually paucisymptomatic, so are restored electively. The main purpose of this study is to assess the trends in hernia repair surgery before and during the pandemic period, analyzing an Italian hospital series of 390 patients, in an attempt to quantify the negative impact regarding social costs derived from the COVID-19 outbreak. Moreover, we want to focus on the concept of apparently minor pathology as herniaplasty, which could represent a life-threatening condition for patients. Methods. The study population consisted of all patients operated for inguinal hernia in a general surgery unit from 2019 to 2021, divided into a pre-pandemic and a pandemic period. Results. The COVID-19 pandemic increased urgent operations in a complicated setting. A statistically significant difference was found regarding the trend of hospitalization length, as well as a strong positive correlation between the severity of hernia and the hospitalization length. Conclusions. During the pandemic, it has been registered a mishandling of inguinal hernias to the detriment of both the healthcare system and patients, due to multifactorial issues and, in particular, to the restrictions imposed by the regional government that erroneously declassed hernia pathology as a minor problem for public health. We do believe that patients, after diagnosis of inguinal hernia, should learn the taxis maneuver for its feasibility and ease of execution, in order to reduce access to emergencies in many cases and likewise to better pain and discomfort perceived, even in the event of unexpected worldwide healthcare scenario. Hollow viscous perforation in blunt abdominal trauma, a 14-year experience from a trauma center. Background: isolated perforations of hollow viscous, HV, represent less than 1% of injuries in blunt abdominal trauma, BAT. When they do present, they are generally due to high impact mechanisms in the segments of the intestine that are fixed. The aim of this study is to determine the incidence of major HV injuries in BAT at the Dr. Domingo Luchini General Hospital, HDL, and address the literature gap regarding updated HV perforations following that, especially in low-income settings. Methods: a retrospective review was conducted on the medical records of patients admitted to our trauma center with a diagnosis of complicated BAT with HV perforation over 14 years. Results and discussion: 761 patients were admitted under the diagnosis of BAT. Of them, 36.79% underwent emergency surgical resolution, and 6.04% had HV perforation as an operative finding. Almost half, 44.44%, of these cases presented as a single isolated injury, while the remaining were associated with other intra-abdominal organ injuries. The most common lesions were grade 2-3 jejunum and grade I transverse colon, affecting an equal proportion of patients at 13.33%. In recent years, an increased incidence of HV injuries secondary to BAT has been observed. Despite this, in many cases, the diagnosis is delayed, so even in the presence of negative diagnostic studies, the surgical approach based on the trauma mechanism, hemodynamic status, and systematic re-evaluation of the polytraumatized patient should prevail. Exploring women's strong preference for women surgeons in breast healthcare. Background: this study challenges the prevalent belief that surgical roles demand masculine traits, potentially limiting women's suitability for such positions. Contrary to this stereotype, we explore the hypothesis that in sensitive surgical procedures, where communal traits are valued, women patients might favor women surgeons. 2 experimental studies investigated women's preferences for a man versus a woman surgeon in a breast exam and breast surgery. Methods: in 2 studies we experimentally tested women's preferences for a man versus a woman surgeon for a breast exam, a non-invasive and non-complicated procedure, and breast surgery, an invasive and more complicated procedure. Study 2 delved into factors influencing these preferences, including patient's age, stereotypical perceptions of women surgeons as communal/warm, past negative experiences with men and women doctors, and previous body-related trauma. Results: women consistently preferred a woman surgeon for both procedures and expressed increased willingness to wait for an appointment with a woman surgeon. However, this preference was less pronounced for surgery than for an exam. Study 2 identified the stereotypical perception of women surgeons as communal/warm as the strongest predictor for this preference, along with previous negative experiences with men doctors and age. Conclusions: while some gender bias persists, this study underscores a notable preference for women surgeons in intimate medical services like breast exams or surgery. This preference holds practical implications for healthcare providers encouraging women's preventive checkups and offers insights for women medical students making residency choices. Proposal of the novel predictive model for postoperative pancreatic fistula and distal pancreatectomy for pancreatic tumor based on preoperative imaging parameters and stapler handling. Background: distal pancreatectomy, DP, using linear staplers is widely performed. However, postoperative pancreatic fistulas, POPF, remain an issue. This study aimed to analyze preoperative risk factors for POP and assess stapler handling. Methods: we retrospectively analyzed consecutive patients who underwent DP for pancreatic tumors using a linear stapler between 2014 and 2022. Preoperative measurements included pancreas to muscle signal intensity ratio, SIR, on fat-suppressed T1 weighted magnetic resonance imaging, MRI. The main outcome was clinically relevant POP of the 2016 International Study Group of Pancreatic Fistulas definition. The predictive ability of the model was compared with the Distal Fistula Risk Score, DFRS, by using the area under the receiver operating characteristic curve, OROC. Results. Among the 81 patients, POP occurred in 31, 38.2%. Multivariate analysis identified computed tomography measured pancreatic thickness, odds ratio, or 1.30, 95% confidence interval, c. 1.05 to 1.61, p equals 0.009, and SIR on T1 weighted MRI, or 6.85, 95% c. 1.71 to 27.4, p equals 0.002, as preoperative predictors. A novel preoperative model, thickness times MRI, TM, index, was established by multiplying these two variables. The TM index exhibited the highest predictability preoperatively, OROC 0.757, 95% C 0.649 to 0.867. In the intraoperative variable analyses, TM index, p less than 0.001, thin cartridge application, p equals 0.032, and short pre-firing compression, p equals 0.047, were identified as significant risk factors for POP. The model's OROC combined with these two stapler handling methods was higher than DFRS, 0.851 versus 0.660, p equals 0.006. Conclusions. The novel preoperative model exhibited excellent predictability. Thick cartridge use and long pre-firing compression were protective factors against POP. This model may facilitate preventive surgical strategy development to reduce POP. Inferior vena cava reconstruction with non-fascial autologous peritoneum, retrospective study and literature review. Background. Inferior vena cava, IVC, resection is essential for complete, R0, excision of some malignancies. However, the optimal material for IVC reconstruction remains unclear. Our objective is to demonstrate the efficacy, safety, and advantages of using non-fascial autologous peritoneum, NFAP, for IVC reconstruction. To conduct a literature review of surgical strategies for tumors involving the IVC. Methods. We reviewed all IVC reconstructions performed at our institution between 2015 and 2023. Preoperative, operative, postoperative, and follow-up data were collected and analyzed. Results. A total of 33 consecutive IVC reconstructions were identified, 7 direct sutures, 8 venous homografts, VH, and 18 FAP. With regard to FAP, 8 tubular, mean length, 12.5 cm, and 10 patch, mean length, 7.9 cm, IVC reconstructions were performed. Resection was R0 in 89% of the cases. 2 patients had Clavin-Dindo grade A complications, 2 grade 2, 2 grade 3, and 2 grade V complications. The only graft-related complication was a case of early partial thrombosis, which was conservatively treated. At a mean follow-up of 25.9 months, graft patency was 100%. There were 7 recurrences and 6 deaths. Mean overall survival, OS, was 23.4 months and mean disease-free survival, DFS, was 14.4 months. According to our results, no statistically significant differences were found between FAP and VH. Conclusions. FAP is a safe and effective alternative for partial or complete IVC reconstruction and has many advantages over other techniques, including its lack of cost, wide and ready availability, extreme handiness, and versatility. Further comparative studies are required to determine the optimal technique for IVC reconstruction. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.